Ariadne string. Ariadne was a fellow in Greek mythology that went into the maze with a string, and the string so he could find his way out. He went into the maze, slew the dragon, and then came back out. The string allowed him to find the way out. The string and the maze might be the problem confronting you, and the string is the compass or the theory behind this kind of work. If you have this idea of looking for edema or lack of blood flow, it's surprising the testing you can do, how complicated situations or complex symptom pathology you can track down by using this, because you always have your compass. But it behooves you to understand the anatomy, the pathology of any certain conditions related to that, so you know what you're trying to treat, or you know you're trying to assess. To see if, for example, tinnitus may have a vascular edema component. The techniques I'm showing you are truly unique. Its mechanism of action is simple and well documented in fluid dynamics. The condition it tests for and treats is ubiquitous to vertebrates, and invertebrates too, I believe. Most of our body components are poroelastic and therefore contain extracellular fluid. By squeezing these tissues, the fluid will move out of the areas. More scientifically, by decreasing the volume, pressure increases, which in turn causes the fluid to move to a lower pressure area. The mechanism of action is just that. Tissues, from bone to skin, blood vessels to nerves, and lungs to prostate, all behave in the same manner. The volume is decreased by manual therapy procedures such as traction, compression, and torque. Acceleration is a method as well. As mentioned earlier, hypoxia and an increased interstitial fluid pressure is being associated with more and more pathologies. These can range from tendinoses to cancer, ischemic stroke to inflammatory bowel disorder, and low back pain to dementia. We test for and treat elevated interstitial pressure as a result of edema. I behoove the practitioner to understand these diseases. I'm at the computer constantly investigating new findings regarding a patient's complaint. Here's a generic pathogenesis. Tissues react to stress by producing proteoglycans. The proteoglycans are in the extracellular matrix. They absorb water through osmosis and by being hydrophilic. The pressure now rises. The original stressor could be mechanical, could be chemical, thermal, light, noise, pain, psychological. The stressor may have been a one-time event or may be ongoing. Once the pressure is elevated, symptoms and disability ensue. In testing the patient, we load tissues using the mechanism of action explained above and look for a response. The patient's responses mean everything. Only they can give a case history, say where the problem is, and whether the test is affecting the correct tissues, and giving feedback during the procedure. To sum up, we have a simple mechanism of action to assess for and treat the pathology that persists itself in many ways. The presenting problem may seem very intricate, but by testing in the above logical matter, that means just string through the maze, you'll not get lost and will have a specific direction to move in. Head and neck are incredibly complicated, so much so that medical specialties only involving one or two aspects of it. Consider fields such as ophthalmology, dentistry, oral-facial surgery, psychiatry, and speech pathology. How can a short seminar possibly address these? There's no such research. There is so much research coming out every month. How can one keep up with it? When is the therapist crossing the line to finding the scope of practice, and can that line even be seen? In this section, I will answer those questions by using two examples. Hopefully, these will help you discover the enormity of your profession. In the first example, the patient presents with an ongoing post-concussive syndrome since being knocked out 5 years ago. The symptoms include tinnitus and vertigo. Over that time, various medical exams and imaging studies have all come up negative. Massage, physiotherapy, counseling, chiro, and exercise therapy have had little effect. Your examination of the patient reveals no red flags and is generally unremarkable. The one noticeable finding is tenderness in the left temporal bone. Could this problem be a result of increased pressure or lack of blood supply? How could I check for that? And if so, how would I treat it? Time for hypothesis testing. A lack of blood flow to certain soft tissues within the cranium may be the cause, specifically the area involving the 8th cranial nerve and inner ear. Which tissue has an elevated pressure? The brain, any structures in the middle or inner ear, or the temporal bone? My big clue in this case is a sensitive temporal bone. Is it tender due to exceedingly high intraosseous pressure? I know transcortical vessels in the temporal bone feed directly into the brain. If blood flow there is compromised, it is likely there will be effects to the brain, cranial nerve 8, and the ear. I also know by flexing the temporal bone, the interosseous pressure will be increased. Lacunar canicular fluid should then drain. To test this hypothesis, the temporal bone is flexed by squeezing the patient's cranium at that level. The testing starts off light as pressure slowly increases within the patient's tolerance. This procedure lasts about 60 seconds and is repeated 2 or 3 times. The patient is giving constant feedback during the entire procedure. In this case, outcomes measures would include less tenderness, a decrease in symptoms, and an improvement in postural sway. If there's no change, look for something else. Let's deconstruct this scenario. The mechanism of action is always the same. There was a stressor, the temporal bone is tender, all previous tests were negative, and previous treatments were ineffective. Therefore, is the disability of the pathology we're interested in? Time to dive into the maze. What is the blood supply, nerve supply, shape, and function of the temporal bone? How about the nerve supply of the vessels of the temporal bone? To continue on this example, there's a general gross anatomy and blood supply. Here's the general gross anatomy and blood supply. The temporal bones are situated at the sides of the base of the skull and lateral to the temporal bones, the cerebral cortex. They are overlaid by the sides of the head, known as the temples, that house the structures of the ear. The lower seven cranial nerves and major blood vessels to and from the brain traverse the temporal bone. The temporal bone consists of 4 parts: squamous, mastoid, petrous, and tympanic. The squamous part is the largest and most superiorly positioned relative to the rest of the bone. The zygomatic process is a long arch process projecting from the lower region of the squamous part, and it articulates with the zygomatic bone. Posterior inferior to the squamous is the mastoid part. Fused with the squamous and mastoid parts between the sphenoid and occipital bone lies the petrous part, which is shaped like a pyramid. The tympanic part is relatively small and lies inferior to the squamous part, anterior to the mastoid bone, and superior to the styloid process. The styloid is a phallic-shaped pillar directed inferiorly, anteromedially between the parotid gland and the internal jugular vein. The arteries of the temporal bone: stylomastoid from posterior auricular branch enters the stylomastoid foramen. Tympanic from the internal maxillary, it passes through the glossarian fissure. Petrosal from the middle meningeal, transmitted by the hiatus fallopii. Tympanic from internal carotid, whilst the carotid canal. Auditory from the basilar, it enters the internal auditory meatus and is distributed to the cochlea, vestibule, etc. You should have a working knowledge of this for a more effective assessment and treatment. And this is just touching on it. What about the clefts, fissures, canals, and foramen along with their content? What about the nerve supply to the blood vessels? It's not only the sympathetics. In the second example, the patient presents with tinnitus and vertigo, which has been ongoing for 3 years after being rear-ended in a car accident. Again, imaging studies and various medical examinations were negative, and treatments up to this point were ineffectual. No red flags during the examination. One outstanding finding was a forward head posture along with an upper cross syndrome. Could this problem be a result of increased pressure and a lack of blood supply? How could I check for it and how could I treat that? Time for hypothesis testing. The lack of blood supply would be in the area of the inner and middle ear. In this case, the actual pressure is elsewhere. The preganglionic sympathetic nerves supplying this area originate in the upper thoracic spinal cord. Misshaped upper thoracic vertebral bodies, discs, and end plates are a result of gravity on a poor posture. That, coupled with the whiplash, may result in an aberrant sympathetic outflow causing compromised blood flow around the inner ear, as well as aberrant signals from the general visceral afferents. By applying the correct pressure to the upper thoracic spine, fluid in the discs, end plates, and vertebral bodies will be redistributed and normal morphology restored. Again, this procedure starts with little pressure and is gradually increased to the patient's tolerance. Outcomes include improved posture, muscle balance, and decrease in symptoms. Let's deconstruct this scenario. The mechanism of action is always the same. Is the disability of the mechanism of action always the same? Is the disability of the pathology what we're interested in? A mechanical stressor was evident. The patient does present with upper cross syndrome. Previous tests were negative, and previous therapies were ineffective. Time to dive into the maze. What is the relationship of the sympathetic nervous system to the inner ear? Does the upper cross syndrome put the patient in a weakened position during whiplash? For example, here's a course of the sympathetics from source to destination. The central autonomic network is composed of both hypothalamic and extrahypothalamic nuclei. Some of these sites regulate sympathetic outflow, whereas others regulate parasympathetic outflow. This structure was first revealed in lesion studies that revealed the multisynaptic connections descending from the hypothalamus and midbrain to preganglionic neurons in the brainstem and spinal cord. Similarly, connections from various limbic brain structures, most especially the amygdala, through the hypothalamus have been demonstrated. The principal pathway of the hypothalamus is the central autonomic. In the central autonomic network is the dorsal longitudinal fasciculus, DLF. The DLF originates in the region of the paraventricular nucleus and descends along the most medial aspect of the third ventricle through the periaductal gray and mesencephalic reticular formation. The DLF continues caudally to the midline near the floor of the fourth ventricle until the closure of the open medulla, where it becomes internalized near the central canal remnant. This position leaves the DLF in ideal position to innervate the periaductal gray and peribrachial nucleus. The mesencephalic raphe nucleus and the locus ceruleus rostrally and the dorsal motor nucleus of the vagus and nucleus ambiguus and the medullary raphe more caudally. The centralized location of the DLF as it continues into the lower medulla and then the spinal cord renders it in perfect location to innervate the parasympathetic and sympathetic neurons of the intermedial lateral spinal cord. As detailed above, the DLF projections are bilateral, though with an ipsilateral dominance due to several points of decussation. Afferent inputs from the periaductal gray peribrachial nucleus and locus ceruleus ascend through the DLF to the hypothalamus.